Rajesh was there with us from the beginning of inception of this PG update. So this time we had a few changes. One is about the days. Actually, we were doing it on bi-weekly on Saturdays, on Saturdays, but from the request of the postgraduates, it has been changed to Thursday, and it will be on second and third Thursday of every month. And to start with, we have the faculty and the postgraduate from the Amrita Institute of Medical Sciences. Dr. Sindhu Balakrishnan will be speaking on the ABG interpretation, and also the postgraduate area will be discussing a journal. Over to our President, Honorable President, Dr. Joe Gurula, for the official welcome.
Am I audible?
Yeah, very much.
You are audible, please, sir. Okay. Respected Venkatagiri, Scientific Coordinator, Dr. Professor Jerry Paul, and my dear colleagues, good evening to you all. Welcome to the new edition of PG Update by ISA Kerala State. I congratulate Dr. Jerry Paul for introducing the new format this year of one topic discussion followed by a journal discussion. I wish him and his team all the best. Over to you, sir, for the deliberations.
Thank you, Dr. Joe. I'll start by introducing the speakers. We have Dr. Sindhu Balakrishnan, who's an associate professor at AIIMS. She's been with us since 2000. She's also a qualified intensivist, having done a 2-year program under the Critical Care Education Foundation, which is also an Indo-Australian training program. And she's also a qualified EDIC. She's got European Diploma in Intensive Care a few years back. And she spends nearly 6 months of her time every year in intensive care. The topic is basically on ABG interpretation. And the second presenter is a first-year junior resident from Amrita again. She'll talk to us about a journal article, one narrative review article on fibroelastic tissues, which is not a very familiar topic for us. So with that, over to Dr. Sindhu for starting the presentation.
Thank you, sir, for your kind introduction. I thank ISA Kerala for giving me this opportunity to be a part of this training program. So let me share my slides. Can you see my slides?
Yeah, very much.
Okay. So I have been interested to talk to you today about interpretation of arterial blood gas. And I'm sure we are always doing this ABG analysis in the operating theaters, in the post-operative units, in the medical ICUs. Even sometimes we ask for ABGs in the ward also if we have a very sick patient. So are we making the most out of this investigation that we are doing? The aim of my today's lecture is my slide is not moving.
Dr. Sindhu, take your time. During this time, forgot to call upon our national president, past president, and the national academic coordinator, Dr. Venkatagiri. Please, sir, please speak a few words. Sir, Dr. Venkatagiri?
Yes. Yes, Paul?
Forgot to call you in between. Sorry.
No
We are the
issues. No.
national coordinator.
Scientific program is more important. My talking is not that important.
Yeah.
Anyway, thank you. Anyway, all the best. After a long time again started the gap. Let it go.
I'm sorry for that confusion. What I intend to talk to you today about is about the one approach to the interpretation of blood gas. So I'm not going to discuss about the physiology of the respiratory gas exchange, which is too extensive, the theories of acid-base regulation, or any other alternative approach to ABG analysis will not be discussed. This is a stepwise approach to the blood gas so that you get maximum information from a tool which we use very often in the hospital, wherever we are rendering our patient care. So the three important informations that we get from the blood gas are: one is about the ventilation, second is about oxygenation, and third is about acid-base status. Very often we skip steps and just look at the acid-base status and forget about the rest of the informations which are available in our blood gas. So this is a blood gas report which comes in our hospital. You can see that besides the pH, the PCO2, the PO2, there are numerous other things which are being reported in the blood gas. So some of the modern machines of blood gas have ability to, they have an added feature of being able to measure the hemoglobin, the hematocrit. Some of them have co-oximetry. Some of them have ability to measure the potassium, the sodium, glucose, creatinine, and even bilirubin. In our machine, we do get lactates also along with all these informations. Now, what are the variables that are measured by the blood gas machine? There are only three variables which are measured by the blood gas machine. They are the pH, the PCO2, and the PO2. And we have specialized electrodes for measuring each one of them. All the other values that you are seeing, that is the bicarbonate, the anion gap, whatever you're seeing, AA gradient, all those are calculated values which are coming in the blood gas that is available to you. I think I'll have to stop my video. It's not going when I... Okay, so the pH, so if you look at the ABG, the pH is the one which is the first value that you see in the ABG. That is the negative logarithm of the hydrogen ion concentration. The pH, as you all know, is calculated by this equation, which is 6.1 plus log base by acid, the base being bicarbonate and the acid being the carbon dioxide in the blood. The normal pH of blood is between 7.35 and 7.45. I'm sure you all will be knowing this. Now, there are certain things before you analyze the ABG that we should make sure of. One of the things is when you're taking a sample of blood gas, it is better that if we can take the sample using a glass syringe. Now, the absorption of oxygen and carbon dioxide is very much minimal if you use a glass syringe when compared to a plastic syringe. And also, the glass syringe has less resistance than a plastic syringe. And so the formation of bubbles inside the ABG syringe will be less if you are able to use a glass syringe. But I know nowadays we are not using glass syringe and all of us have moved to plastic syringe. The next thing about ABG is that heparin is the recommended anticoagulation, and we should avoid using EDTA, citrate, and other oxalates. Avoid air bubbles while taking a blood gas because the air bubbles will affect the oxygen and the carbon dioxide values in the ABG. And the ABG must be interpreted always in relation to the FiO2, the temperature, the source from where you're getting the blood gas sample, the ventilator settings, and appropriate changes must be made whenever you find an abnormality in the blood gas. And the last important thing is to analyze the samples as soon as you take the ABG. It will be good if you have a ABG machine in the unit or close to where you're going to send the sample. Now, there are certain factors which are going to affect your ABG values. Very, very high blood count as seen in leukemia. Those situations, the PO2 will be falsely low in these situations because these very high blood count, very high WBC counts have a very high metabolism which consumes oxygen and increases the carbon dioxide production. So you may get a normal saturation in the patient, but the PO2 and the PCO2 values will be abnormal in these kind of patients when you take the ABG. Similarly, excessive heparin in the syringe. Suppose you use heparin where you have 5,000 units in 1 ml, you're going to get a metabolic acidosis in the ABG. So all these things should be kept in mind while you're assessing the ABG. Now, what happens when you have an air bubble in the ABG syringe? Now, the oxygen content in the bubble will be higher than that in the blood, especially if your patient is hypoxemic. Now, because the concentration of oxygen in the bubble is more than that in the blood, the oxygen will move from the bubble to the blood, and this will lead to a spuriously high PaO2 in the sample. Similarly, if you have a bubble and the carbon dioxide in the bubble will be lower than that in the blood, and so the carbon dioxide will again move across the concentration gradient into the bubble, and you will get a falsely low PaCO2. So this is why it is very important that you remove all air bubbles as soon as you take the sample. And don't keep flushing, and so then the oxygen will enter into the blood and you will spuriously have a high value of PO2. Now, this was just a few important things that you should keep in mind while you're taking a blood gas sample. Now, I will be going into the steps of ABG interpretation, which will be useful for you not only at the bedside, and if you're an exam going PG, you're going to find it useful while you're going to interpret the ABG, which is being given to you during the exam. So the first step in an ABG is to check the validity of the ABG. Now, why do we need to do this checking the validity? It is important to check the validity so that you do not wrongly go on treating a patient just based upon your ABG. So the validity of an ABG is calculated by the product of the hydrogen ions and the bicarbonate divided by the PaCO2. And this should always be equal to 24 plus or minus 2. As you have seen already, you're not directly measuring the hydrogen ion concentration. So you need to calculate the hydrogen ion concentration from the pH or based upon certain tables or things which I'm going to tell you. The hydrogen ion concentration in the blood can be measured roughly as 80 minus the last 2 digits of your pH. Similarly, there is another rule, which is the Cassirer-Blake's rule. For every 0.01 change in pH, hydrogen ion changes by 1 nano equivalents per liter. That is, if your pH changes by 0.01, you're going to have a change in the hydrogen ion concentration of 1 nano equivalents. Now, this is another chart which is available where you can see the correlation of the pH to the hydrogen ion concentrations. So roughly when you have a pH of 7.40, your hydrogen ion concentration is 40. So you can see that as the pH is dropping, the hydrogen ion concentration is increasing. And as your pH is increasing, the hydrogen ion concentration is decreasing. So this table, if you carry it around, you will be able to check. Now let's do an example. This is an example of the pH, where the pH is 7.24, PaCO2 is 30, the bicarbonate is 14, and hydrogen ion concentration based upon that 80 minus last 2 digits of pH is 56. Now the validity of the ABG is 56 into 14 divided by 30, that is you're multiplying the hydrogen ion concentration by the bicarbonate divided by the PaCO2. So this ABG, if you calculate this, you are getting a value of 26, And so this ABG is a valid ABG. Similarly, if you look at this chart, at a pH of 7.25, the hydrogen ion concentration is 56 based upon this chart. So whatever you're using, you will get. So you might as well use a simpler way of, this is a simpler way, 80 minus the last 2 digits of pH into the bicarbonate divided by the PaCO2 is one way of checking the validity of the ABG. Now, the next step in the ABG assessment is to check the PaCO2. That is the step 2. You look at the PaCO2 because it will give you an idea about the ventilatory status of the patient. The normal PaCO2 is between 35 and 45 millimeters of mercury. And if you have a PaCO2 of more than 45 millimeters of mercury, you would say that the patient is hypoventilating, and a PaCO2 of less than 35 millimeters of mercury, you will think that the patient is hyperventilating. Now, the PaCO2 depends upon the balance between the carbon dioxide production and the carbon dioxide elimination of the patient. Now, at this stage, even if you diagnose a hypoventilation or a hyperventilation in your ABG analysis, please do not adjust the ventilator settings, because there are further steps in your evaluation which may modify your thoughts about altering the ventilation in this patient. Now, the PaCO2 is the ratio between the amount of carbon dioxide produced and the amount of the rate at which the carbon dioxide is eliminated, which is dependent upon the minute ventilation minus the dead space, or it is actually the PaCO2 is equal to the carbon dioxide produced in the body by the alveolar ventilation of the patient. Now, what are the factors which will increase the carbon dioxide production in the patient? Because when you have fever, your carbon dioxide production will be increased. If you're having thyrotoxic storm, you're going to have a high carbon dioxide production. Malignant hypothermia is another situation where you're going to have a high CO2 production. Overfeeding, CNS trauma are other reasons where your carbon dioxide production is going to increase. Now, what are situations where your carbon dioxide production is decreasing, where the body temperature is low, where you are having hypothyroidism or mixed edema, coma, drugs, anesthetic agents, like when you sedate and paralyze a patient, the amount of carbon dioxide produced in the body is going to be less. Now, what are the factors which will increase the minute ventilation? These are some of the factors like anxiety, pain, head trauma, metabolic acidosis, pregnancy, asthma. They all increase the minute ventilation in the patient. And similarly, factors which decrease the minute ventilation are CNS depressant drugs, CNS disease, metabolic alkalosis, muscle weakness, sleep apnea, hypothyroidism, and COPD. So these are some of the situations where the numerator, I have already said, the numerator are factors which will increase the carbon dioxide production in the body. And also I've discussed about the factors which decrease the carbon dioxide production in the body, and some factors which will increase the elimination of carbon dioxide from the body, and those factors which decrease the carbon dioxide elimination. Similarly, if you have a increase in dead space, which can be an increase in the anatomic dead space, the alveolar dead space, or the physiological, and because the sum of the anatomic and alveolar dead space, you are going to have a decrease in the minute ventilation if you have any increase in the dead space. So you will have to see if any of these factors exist in your patient while you are analyzing the ABG of the patient. So always the ABG should be analyzed in relation to the clinical situation of the patient, the ventilatory parameters of the patient. Now, coming to the third step, after checking the validity and the ventilatory status of the patient, we come to the oxygenation of the patient. And this should be always analyzed in relation to the FiO2 that you are administering to the patient. Roughly, you should have a PaO2 of 5 times the FiO2. That is, if your patient is breathing 21%, that is room air, you should get a PaO2 of 100 if the patient is breathing, if the patient has a normal lung. If the patient is breathing 100% oxygen, you should get a PaO2 close to somewhere between 500 or above. And always when you're assessing the oxygenation, ensure that the sample has been taken from an arterial line, because if it is being taken by a direct puncture, there is always a risk of venous admixture or venous mix along with the arterial sample. And also make sure that your ABG analysis has been done immediately after the sample, not that the sample was lying around and then taken. So then your PaO2 values are going to be abnormal. Now, this is something which we learn in the first year of anesthesia training, where you identify hypoxemia in patients. That is, if you have a PaO2 of above 80 millimeters of mercury in somebody who's breathing room air, you would say that the patient's oxygenation is normal. If the patient's PaO2 is between 60 to 79, you call it as a mild hypoxemia. And somewhere between 40 to 59, it is called as moderate hypoxemia. And if the PaO2 is less than 40, then it is called as severe hypoxemia and needs intervention. So if you get a PaO2 somewhere less than 80, it is important that you just see it and not act. You have to administer oxygen to the patient. Now, the next step in the oxygen assessment is to look at the PF ratio. Now, as you all know, the 3 classes of ARDS, if you have a PF ratio between 200 to 300, it is called as mild ARDS. 100 to 200 is moderate ARDS, and less than 100 millimeters is a severe ARDS. Now, the last step in the oxygen analysis is to look at the alveolar arterial oxygen gradient. Now, this will help you to differentiate the different types of hypoxia that the patient has. Now, this is the alveolar gas equation, the first line, where the PaO2 is the alveolar oxygen that is equal to the FiO2 into the barometric pressure minus the water vapor pressure minus PaCO2 by the respiratory quotient. To get, this is the equation for you to calculate the alveolar oxygen concentration. And from this, you need to subtract the arterial PaO2, which is available in the ABG, to get the AA gradient. So in a patient who's breathing room air, the barometric pressure is 760 millimeters of mercury. The water vapor pressure is 47 millimeters of mercury. And the difference is usually 713. If you multiply this by 0.21, you will get 150. And if you take a normal PaCO2 of 40 divided by 0.8, you will get this fraction as 50. So the alveolar PaO2 in a patient who's breathing room air is 100 millimeters of mercury. The AA gradient is the in a patient who's breathing room air, the PaO2 is something above 80 millimeters of mercury. So the AA gradient will be 100 minus 80, which will be 20 millimeters of mercury. The normal AA gradient is, in a patient who's breathing room air, is between 5 to 25 millimeters of mercury. In patients who are breathing 100% oxygen, you can accept AA gradient of up to 50 millimeters of mercury. Now, the AA gradient will be widened in situations where you have diffusion defects like in pulmonary edema, interstitial lung disease, patients who have VQ mismatch because of pneumonia, patients with right to left shunt like in patients who have ARDS. So this high AA gradient will help you to identify the cause of the hypoxemia in the patient. Similarly, whether oxygen administration will help to improve the oxygenation in the patients. Now, these are the common causes of hypoxemia in any patient that you should look for. They are hypoventilation, the VQ mismatch, the shunt, diffusion defects, and low inspired oxygen. Of these, the hypoventilation and low inspired oxygen will have a normal AA gradient when compared to the other 3 situations. Calculating the AA gradient daily in your patient will help you to understand if the lung is improving or if the patient is worsening. If the patient has an ARDS, it will help you to identify whether the patient is improving or worsening. So till now, I have discussed the first 3 steps of ABG analysis, which is the first one is to check the validity. The second step is to check whether the patient has a normal ventilation or is he hypo or hyperventilating. The third step is to look at the oxygenation, where you are going to identify mild, moderate, severe hypoxemia, or whether your patient has a mild, moderate, or severe ARDS. And you're going to calculate the AA gradient, which will help you to identify whether the cause of hypoxemia has a high AA gradient or a low AA gradient. So now coming to the fourth step, very often we skip these first 2-3 steps and then go on to just assessment of the acid-base status of the patient. The next step is to check at the acid-base status. The normal pH, I already told you, is between 7.35 and 7.45. Any patient with a pH of less than 7.35 is said to have an acidemia, and this acidemia can be because of metabolic causes or it can be because of a respiratory cause. So you can have metabolic acidosis or a respiratory acidosis, and if the pH is more than 7.45, you would call it as a metabolic alkalosis, and respiratory alkalosis can be there if your pH is more. Now, how do you identify each one of these disorders? So this is just the normal values in the ABG before I go on to the next step. That is the pH, normal pH is between 7.35 to 7.45. PCO2 is between 35 and 45 millimeters of mercury. The PaO2 should be more than 80 millimeters of mercury in a patient breathing room air. The bicarbonate is somewhere, it should be 24 millimoles per liter or 24 milliequivalents per liter. The anion is usually 12 to 14 millimoles per liter. Now, coming to simple acid-base disorders. So if your patient has a low pH, we look at the PaCO2 and the bicarbonate. If the pH is low and the bicarbonate is low, you would call that acidosis as a metabolic acidosis. Similarly, if you look at the pH and the pH is low and the PCO2 is high, you would call it as a respiratory acidosis. Similarly, if you have a high pH and a bicarbonate is also high, that is called as a metabolic alkalosis. And if you have a high pH and a low PCO2, you would call it as a respiratory alkalosis. So the fourth step involves the identification, the relation of the pH to the PCO2 and the bicarbonate, and thereby trying to identify what disorder the patient has. Now, coming to the step 5. The step 5 involves the check of the compensatory response of the body. So if a patient has a respiratory acidosis, the automatic compensation by the body is a metabolic alkalosis. That is, the body always tries to retain the bicarb and tries to bring back the pH to normal. The body's responsibility is to maintain a normal pH between 7.35 and 7.45. So the next step in your ABG analysis is to look if your patient has an adequate compensatory response. So there are different buffer systems which are very important in our body, which helps to maintain the pH within the normal level. So the buffers that are present, inside the cell as well as in the extracellular fluid. In the extracellular fluid, the most important buffer system is the carbonate and the bicarbonate buffer system, which helps in buffering 53% of the acid-base changes which occur. The intracellular proteins play an important part in buffering in case the patient develops a metabolic acidosis. So what is the time frame in which this buffering system acts? When the patient develops acidosis, the immediate response is of the extracellular buffering, that is the bicarbonate buffer system acts immediately. Within a few minutes to hours, your respiratory compensation will start to occur. And within 2 to 4 hours, you're going to get your intracellular buffering system. And for the renal compensation to develop, you're going to take hours to days for the kidney to start compensating. So this is just for you to have an idea so that you can remember that when your patient develops an acute respiratory acidosis, the renal compensation is going to take a long time for the patient to develop and retain the bicarbonate. So now coming to the compensatory responses in simple acid-base disorders. So in metabolic acidosis, as I discussed earlier, the pH is going to be low, the bicarbonate is low. And this low bicarbonate is the one which is accounting for the metabolic acidosis. And as a compensatory response, the PaCO2 goes down because the body tries to create an alkalosis, respiratory alkalosis, to try and bring back the pH to normal. So if you look at it in metabolic acidosis, your pH is low, the PCO2 is low, and the bicarbonate is low. So all the three things are moving in the same direction. Low pH, low PCO2, low bicarbonate is highly suggestive of a metabolic acidosis, but you should also look up, I'll tell you in the coming slides, that it may be another disorder also along with the metabolic acidosis. Now, the second disorder that we will discuss is the metabolic alkalosis. The metabolic alkalosis, patients have a high pH, and this is accounted for by the high bicarbonate. Now, because the pH is high, the body tries to retain in the carbon dioxide by the respiratory system. And so the PaCO2 is also high. So in metabolic acidosis, you will see that the pH, PCO2, and the bicarbonate are all high in metabolic alkalosis. So in metabolic disorders, the pH, PCO2, and the bicarbonate move in the same direction. In the respiratory acidosis, you're having a low pH, and the low pH is because of the high PCO2 that the patient has. And this high PCO2 is compensated for by a retention of bicarbonate by the kidneys and by the action of the bicarbonate buffer system. So you will have a high bicarbonate in respiratory acidosis. So in this, the pH and the compensatory mechanisms are moving in the opposite directions. You have a low pH, but the PCO2 and the bicarbonate are high. In respiratory alkalosis, you have a high pH, and the high pH is because of a washout of the CO2. The CO2 is low, and the compensation for this is by a low bicarbonate in the patient. So you can see that again in respiratory alkalosis, you have a high pH, but the PCO2 and the bicarbonate are low. So if you look at it, in metabolic disorders, the pH, the PCO2 and the bicarbonate all move in the same direction, whereas in respiratory disorders, the pH moves in the direction opposite to that of PaCO2 and bicarbonate. So now let us see the compensatory what is the compensation that occurs in each of the disorders. That is, how much should the body compensate if you have a metabolic alkalosis? You cannot endlessly retain the CO2 in the patient. So how much should the body retain the CO2 to try and bring back the pH to normal? So this I have already said, in metabolic alkalosis, increase pH and bicarbonate and PCO2. Now this is an equation which can be used to see what is the expected PaCO2 in a metabolic alkalosis, because the compensated response of the body in metabolic alkalosis is to retain the carbon dioxide. So in the expected PaCO2 is 0.7 into bicarbonate plus 21 plus or minus 1.5. So that is for every 1 millimole change in bicarbonate, the PCO2 increases by 0.6 to 0.7 millimeters of mercury. So all this I have said, it will be good if you can check the urinary chloride and the blood pressure in patients with metabolic alkalosis. So let's do a simple calculation. If you have a pH of 7.54 with a bicarbonate of 38, the change in PCO2 in this equation is you can also use this change in bicarbonate by 2 will roughly give you the PaCO2. If the change in bicarbonate is 14, that is, if you take bicarbonate, normal bicarbonate is 24. When you have a bicarbonate of 38, you have a difference of change in bicarbonate of 14. That 14 divided by 2 is 7. So the PaCO2 should rise by 7 millimeters of mercury to have an adequate compensation in the patient. Now, if your PaCO2 is something above 47, that means the patient is not compensating fully, but patient has another disorder along with metabolic alkalosis. That is, if your compensation is more, that is, if you're getting a PCO2, actual PCO2 is more than 47 in the patient, it suggests that the patient has an associated another disorder, that is a respiratory acidosis. Now, if you check with the other formula, 0.7 into bicarbonate plus 21, 0.7 into 38 plus 21, that will give you an answer of 47.6. So whichever way you calculate, you are going to get, you have to find the respiratory compensation for any degree of metabolic acidosis to know if your compensation is full or you have another disorder in the patient. I hope it is clear. Now, what are the causes of metabolic alkalosis? I told you, you could do a urinary chloride. A urinary chloride of less than 10 is suggestive of hypovolemia. It could be because of other causes like vomiting, nasogastric suctioning, dehydration, diuretics, hypokalemia, magnesium deficiency. And these patients with a urinary chloride less than 10 are usually responsive to volume. And this metabolic alkalosis, when you're trying to correct, you need to correct the volume of the patient to get the alkalosis corrected. Now, if the urinary chloride is more than 20, you should look for other causes like high renin, low renin, where you can get it in Conn syndrome, Cushing syndrome, Liddle syndrome, or in estrogen secreting tumors. So this is a little bit about metabolic alkalosis. So now I have told you about the identification of the acid-base disorder and the compensatory response of the body to the acid-base abnormality the patient. I've discussed about metabolic alkalosis, the formulae for calculating the compensation for a degree of metabolic alkalosis. Now, the next step is to look, now suppose if you have a metabolic acidosis, how do you identify what is a compensatory response for the metabolic acidosis? This is done by the popular Winter's equation. The expected PCO2 should be looked at. The expected PCO2 is 1.5 into bicarbonate plus 8 plus or minus 2. So roughly, if you look at it, the PCO2 will be equal to the last 2 digits of the pH. If you want to quickly find out what is the expected PCO2 for a degree of acidosis, you just look at the last 2 digits of the pH. That should be the amount of bicarb PCO2 that you should have. Now, the PaCO2 will decrease by 1 to 1.3 millimeters of mercury for every 1 millimole change in bicarbonate. So these are 2-3 things which you can use. You can use whichever is convenient to you. Now, let us do a simple workout. If the bicarbonate is 60, then assuming that the normal bicarbonate is 24, the change in bicarbonate is 8. The change in PCO2 should be 40 minus 8, which is 32. So if you compare this with the equation 1.5 into bicarbonate, which is 16, plus 8 will give you 24 plus 8, which is 32. So whichever formula you use, you can use either change in bicarbonate is equal to the change in PCO2, or you can use the Winter's equation, which is 1.5 into bicarbonate plus 8, which will give you the expected PCO2 for a degree of acidosis. So this is the compensatory response in metabolic acidosis. Now coming to the respiratory disorders, in respiratory acidosis, I already discussed the pH is low, the PCO2 and the bicarbonate are high. The bicarbonate is a compensatory response in respiratory acidosis. In respiratory alkalosis, the pH is high, the PCO2 is low, and the compensatory response of the body is by decreasing the bicarbonate. Now, this is slightly different. For every 10 millimeter change in PCO2 in a respiratory acidosis, when the disorder is acute, you get 1 millimole increase in bicarbonate. In chronic respiratory acidosis, the change in bicarbonate will be 3 millimoles per liter. And respiratory alkalosis, 2 millimoles decrease in acute respiratory alkalosis, and in chronic respiratory alkalosis, the bicarbonate decreases by 4 to 5 millimoles. So we commonly remember it as 1, 3, 2, 5. So in acute chronic respiratory acidosis and alkalosis, 1 in acute, 3 in chronic, and in respiratory alkalosis, we remember it as 2 in acute, and in chronic, it is 4 to 5 millimoles per liter. Now, I don't know whether this will be useful, but this is a simple formula which will help you to identify acute on chronic carbon dioxide retention, which I think if you're interested, I can discuss with you. You could send your doubts over to ISA this thing, and I can share it with you because it is little complex and I think it needs more interaction to discuss. Now, what are the causes of respiratory acidosis? You should look for drugs, head injury, stroke, obesity, COPD, neuromuscular disorders. The causes of respiratory alkalosis are pain, anxiety, brain trauma, tumor, salicylates, salicylate overdose, early asthma, pulmonary embolism, pregnancy, liver disease. Now, suppose your patient has a metabolic acidosis, then you should go to the step number 6, which is to calculate the anion gap for the patient. The anion gap is the sodium minus chloride plus bicarbonate, and the normal value is between 10 to 12 plus or minus 2 milliequivalents per liter. It is important that we calculate the expected anion gap for any patient. And for this, we need to measure the serum protein. So in our body, we have unmeasured anions and cations, and the difference between the unmeasured anions and the unmeasured cations should be equal to 12 to maintain a normal acid-base status. Now, it is one important thing that we should understand is that albumin carries a lot of negative charges on its surface. And so it accounts for most of the unmeasured anions in the blood. So if you have a low albumin, your anion gap will be low in that patient. So there is a formula that is when you have a low of albumin, for every gram decrease in albumin below 4.4, the anion gap decreases by 2. So that is why you need to calculate, as I mentioned here, you need to calculate the expected anion gap based upon the albumin value of the patient. So I'll tell you why that is important. So if you have an albumin of 2, the expected anion gap is 12 minus 4. For every gram, you take 2 decrease in the anion gap. So if for 2 gram from 4 gram, you have a 2 gram drop in albumin. So the expected anion gap in that patient is 8. Now, next step is to calculate the gap ratio or the delta anion gap. Delta anion gap is the measured anion gap minus the expected anion gap. Expected anion gap should be done, that is, you make the corrections for the anion gap based upon the albumin value of the patient. And the measured anion gap, you have to measure, you have to calculate it from the formula of sodium minus the chloride plus bicarbonate. Similarly, you need to find the delta bicarbonate, that is the expected bicarbonate minus the measured bicarbonate. So in a patient with acidosis, suppose you have the measured and bicarbonate as 14 and the expected bicarbonate is 24. So the delta bicarbonate is 10 in that situation. So in metabolic acidosis, we need to calculate the gap ratio, that is the delta anion gap by the delta bicarbonate, which is, if it is equal to 1, it is a purely high anion gap metabolic acidosis that the patient has. If the gap ratio is less than 1, it is suggestive of a associated normal anion gap metabolic acidosis. And if it is more than 1, it is suggested that the patient also has an associated metabolic alkalosis. So from this, you can see that there are so many different types of metabolic disorders can coexist. So let us look at some of the causes of high anion gap. That is methanol poisoning, uremia, diabetic ketoacidosis, all types of ketoacidosis, diabetic, starvation, alcoholic, all of them will have a high anion gap metabolic acidosis, paraldehyde, iron, INH poisoning, lactic acidosis, ethanol, ethylene glycol, salicylates, aspirin. These are some of the common causes of high anion gap metabolic acidosis. Now, causes of normal anion gap metabolic acidosis can be divided into GI causes and renal causes. GI causes like diarrhea, ileostomy, uretrosigmoidostomy are some of the GI causes where you can have a normal anion gap metabolic acidosis. Other causes are drugs like magnesium, cholestyramine, AC inhibitors, NSAIDs, trimethoprim, TPN are some of the drugs which cause a normal anion gap metabolic acidosis in the patient. The renal causes are proximal RTA, distal RTA, type 4 RTA, renal failure, mineralocorticoid deficiency. These are some of the causes of normal anion gap metabolic acidosis. Now, can you get a negative anion gap? Yes, sometimes we get a negative anion gap, and these are some laboratory abnormalities which can occur in the patient, because one is because of underestimation of serum sodium. That is, if you have very high sodium values, the value of sodium in your measured sodium concentration may be low, and it may show us hyponatremia in the patient. Second thing is where you overestimate your serum chloride. This happens in severe hyperlipidemia, where the caloric method grossly overestimates the serum chloride. The third situation where you can get a negative anion gap is with the high serum bromide levels. In patients who are having chronic ingestion of pyridostigmine, like in myasthenia, this results in high serum bromide levels. And this, because most laboratories report bromide as chloride, you get a pseudo hyperchloremia in the patient. Now, the seventh step in your ABG analysis is to look at the osmolar gap. This is especially important if you're suspecting some sort of poisoning in your patient. In this, if you measure the osmolality and calculate the osmolality, the normal difference should be between 10 to 12 milliosmoles. Now, if the patient has high osmolality substances, your osmolar gap will be higher, and this helps you to identify that there is some toxin in the blood. So the calculated osmolality is 2 times sodium plus glucose by 18 plus blood urea nitrogen by 2.8. Now, the causes of high osmolar gap are some of these poisonings: ethanol, methanol, ethylene glycol, mannitol, glycine, sorbitol, isopropranolol, X-ray dyes. These are all substances which increase the osmolality of the blood, and thereby your osmolar gap will increase. The last step in your ABG analysis should be to look at the lactate. A normal lactate level is less than 2 millimoles per liter. Any lactate above 8 millimoles carries a grave prognosis or a bad prognosis for the patient. Now, lactates, different types of hyperlactatemias are there: type A, type B. Type A is usually because of shock, severe hypoxemia, severe anemia, carbon monoxide poisoning. Type B can be divided into B1, which are due to disease conditions, and B2, which is because of drugs. Common drugs that we use which cause hyperlactatemia are epinephrine, continuous nebulization with salbutamol, especially if the patient comes with an acute exacerbation, alcohols like ethanol, nitroprusside, metformin, commonly used drug like linezolid. These are some of the drugs which are associated with hyperlactatemia. Type B1 is which occurs in sepsis, liver failure, thiamine deficiency, malignancy, diabetes, pheochromocytoma. So with that, we come to the end of the steps of ABG analysis. So the first step in your ABG analysis, I'll just recap, is to look at the validity. The second step is to look at the ventilatory status of the patient. The third step is to look at the oxygenation. In the oxygenation, you look whether the patient has mild, moderate, or severe hypoxemia, whether the patient has, what is the PF ratio of the patient, what is the AA gradient in the patient. Then you look at the acid-base status, try to identify the correlation between the pH and the PCO2 and bicarbonate. And the fifth step is to look at the compensatory responses. The compensation in metabolic alkalosis is 0.7 into bicarbonate plus 21 plus or minus 2. Then in metabolic acidosis, you use the Winter's equation, 1.5 into bicarbonate plus 8 plus or minus 2. The changes in respiratory compensation. What is the compensation of bicarbonate? Acute respiratory acidosis, the bicarbonate increases by 1, and in chronic respiratory acidosis, the bicarbonate increases by 3. And in acute respiratory alkalosis, the bicarbonate increases by 2. And in chronic, it decreases by 4 to 5. Then the next step is to look whether your patient has a metabolic acidosis. If the patient has metabolic acidosis, you look at the anion gap. The anion gap is calculated from sodium minus the chloride plus bicarbonate. The normal anion gap is 10 to 12. Then you look at the gap ratio, delta anion gap, that is the measured minus the expected, and delta bicarbonate, which is the expected minus the measured bicarbonate. So you look at the gap ratio. Gap ratio equal to 1 is high anion gap metabolic acidosis. Gap ratio less than 1 is metabolic high anion gap metabolic acidosis with normal anion gap metabolic acidosis. And if it is more than 1, there is an associated metabolic alkalosis. Now, can we have coexistence of acid-base disorders? Yes, we can have coexistence. The only disorders which cannot coexist are respiratory acidosis and respiratory alkalosis. You cannot have these two disorders, these two respiratory disorders to coexist, but you can have combinations of the other along with metabolic. You can have different combinations of respiratory. You can have two metabolic disorders. As I told you, from the gap ratio, you can identify normal anion gap, high anion gap, and metabolic alkalosis. One metabolic disorder can occur together with a single respiratory disorder. Similarly, you can have two metabolic disorders with a respiratory disturbance also. Can you get a normal pH with abnormalities? Yes. If you have no acid-base disturbance also, you have to look at the carbon dioxide and bicarbonate first, and then you can be sure if the pH is normal and the carbon dioxide and the bicarbonate are within normal range, then that means there is no acid-base disorder. You can have a single acid-base disturbance which is being fully compensated. Like you can have a compensated respiratory alkalosis with a normal pH. You can have a compensated metabolic acidosis also. Similarly, you can have at least two acid-base disorders which can coexist simultaneously. Like you can have a primary respiratory acidosis with a primary metabolic alkalosis, where your both CO2 and bicarbonate will be high in this situation. So any type of combinations are possible in the ABG analysis, and the stepwise approach to ABG will help you so much in your clinical practice as well as in your exam, so that you will not miss disorders, and you can treat the patient accordingly. So this is why I said that just by seeing a high PCO2, don't change the ventilatory settings alone, but analyze your ABG completely before you make changes in the management of your patient. So this is the quick recap, which I already discussed with you. Don't forget to look at the osmolar gap and lactates, which I've missed in my recap. So with that, I think I have come to the end of the approach to ABG interpretation, which is like devoid of any, I mean, I haven't gone into details of the physiology and other things. So over to you, Dr. Jerry. Should I go into this thing? I don't know.
Thank you, Sindhu. That's been a wonderful presentation. You've covered. See, if you follow all those 7 steps, there's no way you can go wrong. Okay. And there are times when you see certain blood gas abnormalities, and that might help you start looking for causes. So that may finally help us make a diagnosis in the end. But always remember that you need to have a clinical history along with the blood gas when you're interpreting. And one important thing I want to tell you is that we are not entertaining any questions directly. You can send questions to the chat box and this will be answered at the next weekly presentation time. Okay. So thank you once again, Sindhu, for that beautiful presentation. You've taken nearly 1 hour, and I'm sure every student who's heard will benefit from it. So thank you again. And so then we'll go on to the next our journal club. Our presenter is Dr. Arya B. S. She is a first-year junior resident at Amada, and she's chosen a topic. It's the fibroblastic tissue, isn't it? Okay. Now, if you ask a senior anesthesiologist how many cannula or how many central lines he has put in his lifetime, it may run into thousands. Okay. But do we know what happens when the cannula is inside? We say, okay, the patient is probably having a catheter-related thrombosis, there's pain there, this, that. But I've often been confused about certain situations. For example, I put a cannula. 3 days later, the sister comes and says that, see, doctor, when I'm injecting the drug seems to be seeping through the side of the cannula. Why is it happening? No idea. Okay. Another one, you put a PICC line and the patient comes for the removal of the PICC line after about 6 months. You tug at the PICC line and it's not coming out. Okay. What do you think is happening? So we have all these answers in the presentation by Dr. Arya BS. So are you ready, Arya?
Yes, sir.
All right.
I'll share.
So over to Arya.
Good evening, all respected doctors and Dr. Jaripur sir and Sindhu ma'am, all faculties. Giving me such an opportunity to present this journal club. And I myself, Dr. Arya BS from Amrita School of Medicine, Department of Anesthesia, junior resident. And today's I'm talking about an article in a journal of Vascular Access, August 2020, about the fibroblastic sleeve, the neglected complication of venous access device. The topic of this narrative review is one of the most neglected and misinterpreted of many phenomena associated with the clinical practice of inserting a venous access devices. It is mostly confused with venous thrombosis, bloodstream infection. And main studies on fibroblastic sleeve has been done on a type of VADs, like polyethylene catheters, dialysis catheters, non-tunnel catheter, double lumen dialysis catheter, and silicone catheters. And the presence of vascular access device inside the bloodstream is often associated with the formation of a connective tissue sleeve around the catheter. And its pathogenesis is still unclear, so it is frequently confused with venous thrombosis and bloodstream infection. And this article tried to convey in a systematic form the current knowledge about the pathogenesis, incidence, clinical manifestation, diagnosis, and management of fibroblastic sleeve. And the morphological concept of the sleeve or sheath is quite appropriate since it represents the special feature of creating an envelope that wraps the catheter. The term fibrin is certainly incorrect since the material of the is not fibrin but a structured cellular tissue developed by fibroblasts. And from so many researchers on fibroblastic sleeve, from the year 1971, the sleeve formation by Hostel and others found out that the sleeve formation around the polyethylene catheter bound with graphene benzalkonium chloride heparin was less evident. And from 1996, the O'Farnin and others found out that the connective tissue might be the final evolution of a thrombotic event, even though initially it's fibrin. In 1998, Kriening and others found out that it takes 3 to 7 days to cover the full length of catheter. And in 2001, Saining and others found out that fibroblastic sleeve is made up of a smooth muscle tissue, which is cellular, covered by a layer of endothelial cells in an animal model. In 2021, it is found out that the 3 potential thrombosis sites are the entrance of catheter tip and arising from the vessel vein wall. And 2025, Kaira and others found out that it is like yellowish fibrin-like mass was discovered surrounding the tip of catheter. And in 2006, it is found the author come to the conclusion that the jugular vein catheter placement, histological features, and development of catheter-related sheet in a vine model. In 2018, Sylvia and others found out that it is core-hexidine coated peripherally inserted central catheters reduce the fibroblastic sleeve formation. And the current definition and pathogenesis, it is a connective tissue that envelops the VAD in its intravascular and can be regarded as a kind of foreign body reaction of the blood caused by the presence of the catheter, and this probably occurs in the catheter that remain in place for more than 7 days. and its formation starts very early. Even 24 hours after the insertion of the catheter is completely within 22 weeks. The external surface of the foreign body, that is a catheter, attracts the circulating protein fibronectin produced by the liver. Fibronectin attracts the blood macrophages which sticks to the catheter that differentiate into the smooth muscle cells and fibroblasts, starting the production of collagen, creating a connective tissue that slowly enwraps the catheter. And this is an incidence ratio which shows that the catheter depends on the catheter type. The incidence is highest in a non-tunnel CVC for fibroblastic fibroblast, and catheter-related thrombosis incidence is 38 in a non-tunnel CVC. And it is, while comparing it, it is less in CVC for chemotherapy. Fibroblastic sleeve incidence is 13, and the catheter-related thrombosis incidence is 1.25%. And in the clinical, according to the article, as per the article, in clinical manifestation, it causes the difficult removal of a peripheral inserted central catheter. And the fibroblast is more likely to occur in a short peripheral catheters, that is 5 to 10 centimeter, which stay in place for 2 weeks or more, such as the long peripheral venous catheters in adults and children, or a centrally inserted central catheter in pediatric patients. And this diagram shows the fibroblast still adherent to the catheter wall after the removal of the venous access. And the catheter can be due to malformation due to blockage. And this is a chart which shows the difference between CRT and fibroblast sleeve. And the etiopathogenesis of thrombosis is endothelial damage, and fibroblast is a foreign body reaction. And the molecular trigger, thrombosis is tissue thromboplastin, and fibroblast sleeve is a fibronectin. And type of tissue that forms in thrombosis is thrombus, and sleeve is a connective tissue. And location in thrombus, it will form at the site of vein wall damage, and in case of fibroblast sleeve, it is around the catheter. And the evolution, it is by fibrosis or reabsorption in thrombosis, and fibroblast may be of reabsorption. And while doing ultrasound imaging, a mass obstructing the vein, anechoic and then hypoechoic, mainly attached to the vein wall in thrombosis, and the sleeve all around the catheter, hypo or hypoechoic, mainly attached to the catheter in fibroblastic sleeve. And as a clinical manifestation, there will be signs and symptoms of venous obstruction plus risk of catheter malformation is definitely seen in a thrombosis, and in a sleeve there is only a catheter malformation. And risk of pulmonary embolism is there in thrombosis, and in sleeve there is no risk of pulmonary embolism. And need for venous access device removal, it is rare in thrombosis and rare in both cases. And in thrombosis, can be preventable with anticoagulant, and it is sensitive to thrombolysis, and low molecular weight heparin is the management. And in fibroblast, there is no role for anticoagulants, and it is not sensitive to thrombolysis, and there is no pharmacological management for that. And diagnosis, it can be made by lineogram, venogram, ultrasound, or color Doppler. And the venous thrombosis has a typical pattern of echogenicity, moving slowly from anechoic, a fresh thrombus, to a hyperechoic, all thrombus with thrombosis in course of some weeks. And the hypoechoic sleeve can be easily identified using a color Doppler. And most fibroblastic sleeve become quite hypoechoic, so that they can easily be detected floating inside the vein after a VAD removal, so-called the ghost of catheter. And this is the ultrasound which showing the color Doppler showing the hypoechoic flow, that blood flow between the fibroblast and the vein wall. And the below diagram, it is the residual fibroblast after the catheter removal. And the treatment, the best treatment is usually the removal of VAD. Since the sleeve is made up of a connective tissue, heparin or a thrombolytic drugs have no role either as a prevention strategy or nor as a pharmacological treatment. And after the removal of VAD, The fibroblastic spleen can be easily visualized in an axillary, subclavian or internal jugular or brachiocephalic vein after the removal of a CICC by a simple infra or supraclavicular ultrasound scan with a linear probe. And fibroblastic spleen will be more easily seen in neonates and children. The sleeve around the catheter will persist also in its extravascular tract. There is no reports that they may associate the persistence of a fibroblast sleeve inside the vein with any risk of pulmonary embolism. And this is the residual fibroblast that is in the extravascular tract after the removal of V8. And as a conclusion, the fibroblastic sleeve is inevitable for any VAD as long as it stays in place at least 1 week, but it is almost always harmless and requires no treatment. Although the sleeve may sometimes cause catheter malformation or extravasation, such complication occurs when the sleeve has completely wrapped the catheter in a whole length, typically in a short catheters with at least weeks of duration, or in catheters that remain in place for months or even years, and especially in a tunneled cuffed catheter for a dialysis. And this is my topic of discussion.
Thank you, Dr. Arya, for covering that topic. See, it might be the reason why when you put a cannula which is short, it generally tends to get blocked within about 48 to 72 hours. Okay. And if you put something like a mini midline catheter, which is about 8 centimeter, you get longer dwell time. They say you get up to about 30 days. It might be the time it takes for the fibroelastic sheath to form and then cover the distal tip also. Okay. And it also explains why when you push a drug, it comes out through the cannula track. Okay. Again, the venous access, sometimes you put a cannula today and then the patient comes for surgery the next day. And then when you try to push, you find an obstruction, isn't it? And if you force it, the patient complains of some pain and suddenly there's a giveaway and the drug goes in. Okay, that might be a thrombus that's being formed. All right. So we should understand that these fibroelastic sheaths are probably of not much consequences other than the fact that it causes catheter malfunction. If you want a cannula to last for longer, you may have to use a slightly longer cannula. Okay, maybe like a mini midline catheter or something like that. Okay. So that brings us to the end of the talk today. And thank you again, Arya. That was a wonderful presentation.
Thank you, sir.
We, as anesthesiologists, we always look for reasons for certain things happening. We don't have answers most of the time. Okay. Now, when we have certain topics like that, this actually clears our mind. And we know we are able to explain why certain things happen, right? So I hope it's been a useful thing for everyone. Thank you once again, Arya. Over to Vinil.
Yeah, thank you, Jerry sir, for the excellent session. Actually, you designed it in a very good manner. One general club and the general presentation, which is actually we selected a good topic for that. And the other one also, you started with ABG, the topic which all the PG students, those who want, all the PG students wants to hear that topic in a great eager. So excellent topic presentations, and I'm happy to mention that Dr. Rajesh is also present here, our past academic coordinator of ISA Kerala State Chapter. And I express my sincere thanks to Dr. Sindhu Balakrishnan, professor in transplant anesthesia, working in Amrita Institute of Medical Sciences, Kochi. And I also extend my sincere thanks to Dr. Arya, PG student in Amrita itself. And for more comments, I hand over the mic to Dr. Joe Kurula, our president, ISA Kerala State Chapter. Over to you, sir.
Very excellent presentation by both persons. I hope this trend continues, and I should congratulate Dr. Jerry Paul for choosing both the speakers. Over to you.
And Dr. Rajesh, anything else to add? I think Dr. Rajesh is there.
Dr. Binil, it's excellent beginning. So, always ABG is usually asked for the postgraduates in the practical examinations, and it's of practical relevance to the anesthesiologists who are practicing clinical anesthesia also. And the topic selected, the fibroblastic, I was a bit confused when I heard the topic, but it is now very clear. But it's lucky that it is got no clinical significance, isn't it, Jerry? Dr. Jerry? Not much clinical significance.
Yeah, it doesn't have clinical much significance, but then it explains why certain things are happening. See, we keep on putting candor. We need to know why certain things are happening. So that gives an answer. Why? When you push a drug, why is it coming back? Why is a short candle not lasting very long? Why does a long candle last longer? And again, sometimes I told you, when I started, I spoke about a PICC line thing. Recently, we had a case where a PICC line was inserted about 6 months back. They tried to take it out. It came out few centimeters and it's not coming out any further. And they had to take the patient to the cath lab and then put a snare in and take it out. Okay. And the culprit is most likely a fibroelastic sheath. Okay.
Right. And thank you, Dr. Jerry, for highlighting the topic also. And the student and as well as Dr. Sindhu presented very well. Dr. Arya and Dr. Sindhu. Thank you, Dr. Binil, and over to Dr. Binil.
I think if there is no more discussions and questions, then I think we can wind up the session. And I hope if Dr. Sindhu is willing, she will be sending the presentation to us. We will we will share the presentation in our WhatsApp group. She's agreed.
Yeah, I can send it. I can send my presentation.
So I will convert it to PDF and I'll share in the WhatsApp group. Okay. Thank you all. Shall we wind up the session, sir?
Good night.
Good night. It's not.